At the
Recording has
outset,
started.
I will definitely like to thank the IMA Dombivli for inviting me because we have been giving webinars in these last 3 months because of the pandemic, and this is the first time I'm giving to a local society. So, thanks to the president, Dr. Vandana Daktode, the secretary, Dr. Vijay Chinchore, and all the team of IMA for initiating this webinar and this talk. And of course, the scientific committee of IMA Dombivli chairperson, Dr. Archana Pate, Dr. Ashwini, and Dr. Mansi Karandikar. Thanks to one and all. In case I have missed few names, just excuse me for want of time. We will go to the main topic. And as rightly told by our president and of course by Ashwini, Corona, it is everywhere. Now, definitely losing our own colleagues is what we cannot accept or we cannot really think of. So this situation, I'm sure everybody agrees, has become a big suspense, not only for the pregnant patients, but also for us medical professional or healthcare workers, including our nurses and other assistants. Well, any pregnant patient always is worried whether his or her baby is growing well. Will my doctor be available for my checkup? And the moment lockdown was locked, all modes of transport stopped, every pregnant patient starts getting worried. How will my baby grow? Is it growing well? Is it safe? Is always in the mind, and they want it to be clarified every time. We as doctors definitely want to give best care to the patients, but we are worried about that corona and COVID. Will I remain free during the service or during the care? And that is the fear or the fright with which we are working. It's something not explainable. Every one of us goes through tremendous anxiety and tension day in and day out in the last 3 months. And these were early days. Corona is a very new phenomenon. So very little is known as far as the disease itself is concerned, and its effect on pregnancy and the neonate is still not understood because it is just 6 months since the pandemic of this virus has hit the human beings. So these were the early papers. Can I, the other voice, something is coming and disturbing there in between at the background? Yeah.
No,
Now,
sir.
this very early paper published in Times of India gave a review that from the Chinese study, which China was the first country we all know. So from there, few centers reported that almost 96% of pregnancy women with COVID will have pneumonia. So that is a terrible rate. And even the US Health CDC or the Disease Control Center did included pregnancy in the risk list where they have mentioned it is 5.4 times more likely to be hospitalized, 1.5 times more likely to require ICU admission. And the same Chinese study did come out with the report that 26% premature delivery rates are known, but what it also gave an idea that 50% of these COVID patients are symptom free. Means asymptomatic numbers are much more in pregnancy than in others. So that is something which we cannot explain. But the nice part was the neonatal effect was very minimal. Hardly 8 or 10 children amongst 440 from China reported to be turning out to be corona positive. Now, if I have to tell you, definitely Corona is here to stay, COVID is here to stay to trouble us. We all thought by 6 months we will be, but today we don't know how long. Today or yesterday there was a report from Hindustan Time that the peak will start in May 21 when India has 2.87 lakh cases every day. So, how serious it is going to be for patients, neonate, but definitely we healthcare workers have to be more careful. Can we dodge the corona? Is the biggest question when we are taking care of the patient. Do you think we can run away from this corona? Definitely, I don't think we cannot. But we should be safe. So we should attempt everything to be at least COVID free. Means we don't get the disease. We will see the corona everywhere and anywhere, but it is for us to safeguard ourselves, safeguard our colleagues, safeguard our nurses, our other assistants, OT and others. So precautions for healthcare workers, which has been, I think, enumerated n number of times. Dr. Archana Pate did mention about all those phenomena, so I wouldn't waste much time. But for an obstetrician, this becomes more relevant because any obstetrician will tell you that when the patient is in labor, jour karo, and the cough and the pressure which keeps coming, aerosolization is going to be immense. So in the labor room, all those who are handling the delivery are going to be exposed tremendous to those aerolized particles, and all those measures which are as far as distancing, use of PPE correctly, and I wouldn't comment much on chemoprophylaxis. I think already it was discussed by Dr. Pate the other day, and we are all clear. But definitely, there are some advantages in taking hydroxychloroquine as an prophylaxis. But this recent paper, which I just got around June end, give from by Francisco de Souza and all from Spain. They evaluated about 728 pregnant patients, out of which 589 were diagnosed by RT-PCR and others by clinical assessment only. And what they said that it is too early for us, but the transmission of the virus to the fetus or baby during delivery is still not proven. But they have already found antibodies, both IgM and IgG, in the newborn. Now, IgM cannot cross placenta, but definitely IgM can be produced only with the thyroid gland of the neonate inside the uterus. That means intrauterine infection is known. So that further side effects and long-term effects, we really do not know of those newborn. Amongst the 587 childbirth, 65% were cesarean. Now, the reason for this increased cesarean is obvious. Aerosolization particle, we don't want to sit and monitor and get exposed, and that is why many of the corona patients continue to go in for C-section unless it's a teaching hospital like the LTMG or the Vadia, where the residents already sit in the labor room in PPE, where about 20-25 delivery takes place, where vaginal delivery is still attempted. But for most of us in the private practice, C-section, whether is it a good option, we really do not know. But to get less exposed or to escape from that aerosolization, we feel that maybe C-section is one alternative to come out of that, scare. Now, only 10 neonatal deaths were reported by this whole study, and the 9 newborns who tested positive, they were at various time. Even vaginal delivery, there was positive. Few were tested at 24 hours, few at 53 hours. But these are all very early days, very small number. But definitely, the results show that potential worsening of women infected with SARS-CoV-2 cannot be ruled out, whether the infection is associated with comorbidities or not. But there is a risk of women developing respiratory disorders. This is what that study proved, not that 96% pneumonia, and they can be having other acid base imbalance and among others problems than the rest. But the risk of babies, there is no concrete evidence of vertical transmission, but cannot be ruled out. Though there were cases of abnormal Abgar respiratory distress, fortunately, all the babies who tested positive recovered fully and rapidly. So that is the point which we can assure our patients that nothing usually is reported now, though it's very early days. And from the Mumbai local LTNG, by June end, on my personal communication with the HOD of Sion Hospital, they till June end they had delivered 290 confirmed COVID positive, out of which about 10 newborns were positive. They had a maternal mortality of 7, and healthcare workers or the resident doctors who were involved, 10 of them were already positive and are recovering. Now, this was another report just day before yesterday. Vadia Hospital Maternity, known for its maternity services, and amongst 173, they had 126 deliveries without any maternal mortality. They had about 6 newborns who are infected with COVID, but no morbidity. So that is again a good sign for most of us who are always scared. So what we are scared is about, of course, the infection. So as I said, The proportion of pregnancies affected is still not determined. There is no virus in the amniotic fluid, cord blood, or breast milk in all these studies. Definitely, no evidence of fetal effects or abnormalities has been proved, or fetal growth. Means IUGR doesn't set in because of this infection as of now. If a patient is positive, 14 days waiting and ultrasound after 14 days is recommended, and no evidence of high risk abortion. Preterm labor can occur if the patient has severe COVID disease like distress and other problem. Now, how do we go about? How we as obstetrician and how we practice, or how I do, I'll just take you through those. But first and foremost, we have to make the patients feel safe, that you are always available for them. That itself will increase their confidence, their morale. So always try to remain in touch with them. Through today, we have everything is permitted: WhatsApp, telephone, SMS, website. Then educate them about all those precautions day in and day out. Even you have to, instill it day in and day out, though we all know what are the precautions. And definitely there is a new normal for patients pregnancy visits to the clinic, and also during labor or admission. And today we practice quite a bit of telemedicine, and that is the IMC MCI has given us the permission to go for telemedicine. I wouldn't go into those detail, but it is very simple, very easy. I feel that those who are not doing it should start doing and stay connected with the patient, so that we call our patients less to the clinic. We also get less exposed. They also get less exposed. And anything is permitted, but it has to be done in a correct format, and which were quite simple. You have to follow all those medical legal guidelines so that you don't, get caught up in a wrong tangle. The, what are the measures? Now, this five measures, which has been already told for every common human being: disinfect the surface, keep at least 1 meter distance. But for a pregnant woman in India, we have the habit or the practice of celebrating baby shower or seamonth, which we call. All those social gatherings should be avoided. There can be no pregnancy shoots, and counsel them they should not go and visit their relatives, and even visitors should not come to meet them. Today morning, I was shocked when I was doing a teleconsulting one of my IVF patient from Ulhasnagar. 27 weeks, she said that she is having cold and loss of smell and loss of taste. I said, can you just give me some history whether any of your relatives had COVID or anybody in the building? She said on the 26th of June, she went to visit her Maushi, who was about 65, and 2 days later, she was admitted for pneumonia and she died on 30th of June. And this lady has gone to visit at the 6 month of pregnancy and has got exposed. So that was shocking. That is where we have to keep on telling our patients, please don't do such stupid act. We have the habit that I have to go and see my relative who is sick. People come and see you, pregnant patients. So definitely not permitted. And all these five, which we are all being told: washing hands, stay at home, always keep it in your clinic, give it to every patient in their file, hammer them into the brain, so that this five is the criteria for avoiding COVID or corona. So this should be constantly hammered to everybody's brain, though it has been hammered in the last 3 months so much. As far as diet is concerned, apart from the regular extra care which is required, most of the patients are recommended a little bit of extra vitamin C, vitamin A, zinc, and vitamin D, because these deficiencies, if a patient with corona gets, they
आवाज येत
get
नाही
exaggerated a little. So you have to give them
बाहेर
substitute dose.
बघते
We will come to that particular dose a little later. But for me, PPE is PPE. Protection everywhere and every time for the healthcare workers. Be it the reception desk, even the reception desk should be with that N95 mask, the head cover, the face shield, everything on them. That apart from the distance which has to be maintained with the patient, even the nurse's counter, the sister, even when she's not in front of any patient or any relative, should be having that face shield always on. apart from the doctor who is always ready for the delivery in the PPE kit, even the nurses, when they are working, also they have to wear that shield because in an emergency, suddenly somebody will come in front of you and you will get exposed. And even the sonologist you can see is taking all that precaution. Not only she is in PPE, there is a curtain between the patient and the sonologist who is performing just to avoid exposure because asymptomatic carriers are going to be 50% in pregnancy. That is the huge number. So every other patient could be a COVID carrier. So not only to delivery, everybody has to be in the complete. Even there is a sheet which is put in front of the patient's face so that patient's breathing doesn't come and get aerosolized in front of you. This care is required, so there is protection everywhere and every time. Why I say every time, if you keep the face mask out in your pocket or the shield out, and suddenly you will get a call like we got in a patient who was COVID negative 6 hours after the C-section. Patient had a drop in SpO2 and became breathless. I was called from home rushing because Rohan could not be immediately contacted, but by the time red alert was sent to all the staff rushed and oxygen and other parametric things were taken care. But when we took our X-ray in the evening, this was the X-ray. So looking at this X-ray, even the physician immediately said, "Oh God, it looks like corona." So if we all had gone without that PPE in front of her in that resuscitation time, each one of us would have got exposed. So that is why I tell my staff that every time, even when they are setting
सहा
up,
तास सिझेरियन नंतर तिला झालं म्हणे
the shield has to be there, the mask
त्याच्याकडे
has to be there. That
एका
care
बाईला
has to
सिझेरियन होऊन
be
6 झालंय श्वास लागला तर असं तेच
now.
ऑक्सिजन दिलं
Most of the patients first telephonically only we consult. We don't give them appointment unless they have consulted on the telephone. We ask them their purpose of visit, their complaint. If they're suffering from cold fever, advise them not to come, wait for 2 days. If it doesn't settle, go to the fever clinic run by IMA. But all these particular lists, you have to completely ask them, anybody in that building, anybody in the house has any chance of corona exposure. If not, then only they are given appointment. So the checklist has to be maintained over the telephone before a patient is called the consulting. And at the consulting, definitely there has to be a designated triage area for the screening, which we are very much aware. I wouldn't go into the detail. You have to apply it day in and day out. Every person, the patient, the relative, attendant, whoever is coming, though one person only is allowed, he or she has to be properly screened and asked. They have to fill a questionnaire. You have to have an isolation area for that. And of course, your administration or your somebody supervising them has to be strict because we all become lax if unless we suffer. That is where the tragedy is. Now, as far as antenatal care, gone are the days when a pregnant patient would walk into a doctor's cabin and ask for checkup, my baby is fine. Today, visits have to be minimized and timed. You have to time most of the visit only when a particular or a very serious sonography has to be done. So after the first visit at 7th week, we call the patients for around the 12th, 13th week, and then around the anomaly scan, which is 20 weeks. And after that, till 32 weeks, today we do not call the patients, but they stay connected with you by the WhatsApp, by the telemedicine. In between, they will take the second dose of TT. The first dose is given at 18, 20 weeks. Second dose they take locally, and the GTT or the glucose tolerance test, which is performed routinely, they have to send it by WhatsApp. And the 30-week sonography is not advised these days. We call them at 32 weeks. Clinically, we find that they are okay, then no need of sonography because we don't want them to get exposed to sonologists or the other people sitting around. Even we don't want to get exposed. And all those precautions, which I wouldn't again and again tell about PPE, distancing, hygiene, should be followed. Telemedicine for all minor complaints. And this instruction we give them at the very first visit. As to the next visit is when, and we give them a whole list of numbers to contact, where to send the WhatsApp report. Everything is given so that they are very comfortable and they communicate to you and they can always ask their query with the reception desk. So all these things are given up upfront in their very first visit. And at the ninth month, we instruct them how to come for delivery. We give them this list again. When they're coming for delivery, only one person, at the most, the husband or a female relative, can accompany, and always inform us before leaving home so that the particular room is sanitized, and they will be directly taken to their room of selection of preference. They are not kept at various rooms, because if at all somebody turns out to be little COVID positive, you will have to sit and sanitize the whole hospital. So directly they go into their room where they're going to be admitted. Full labor, they are monitored there, and only at the time they have to come for delivery, they are taken into the labor room. So this care and this advice we continue to give, and each one of us should continue to practice. And as far as ultrasound is concerned, as I said, today the NT scan is still considered significant along with double marker. The anomaly scan at 18 or 20 weeks, and then other scan is not required. You may do a 35 weeks color Doppler. But if a patient gets infected during this time, what to do? It is recommended that if a patient who was posted for NT scan has turned out to be corona positive, she has to wait for at least 3 weeks. At the most, today, NIPT, non-invasive screening test, which is for the chromosomal anomaly, can be advised where only blood test is required, and you can reschedule it after 3 weeks. Anomaly scan also, if it is delayed because of the corona infection, this should not be called for sonography. You have to wait for that 3 weeks before you can come perform. But the patient is admitted seriously, you can perform at bedside, but otherwise for outpatient we do not. And even in third trimester, if required, wait for those 2 weeks before you advise. Now, clinical presentation, it is like what I think day before yesterday Dr. Pate must have enumerated. But as I said, 50% of pregnant patients are supposed to be asymptomatic. But those who have detected, they might be having mild, moderate flu-like symptom, the same features which is there for any common public, but other history and shortness of breath and other aggravation factors we will see. But the maternal disease which is there in pregnancy, like PIH or obesity or diabetes, can become a comorbidity, we still do not know, but you have to elicit their respiratory symptom each time they are going to come. Now, I'll just give you one clinical situation. A patient may get corona positive or turn out RT-PCR positive at any stage in a pregnancy. Now, if she's not near a due date and if there are no symptoms, you can just ask them to quarantine in the same way which the other general public or any other patient is for home quarantine, but all those criteria for home quarantine has to be fulfilled. She should be having the isolated room with toilet facilities. She has to have some caregiver who is also protected, but the girl or the lady should not move around the house. She should not be very free. She should stay inside the room for taking care, all the precautions which is required for home isolation, and she should be, as far as the Indian government Arogya Setu registration app is mandatory for each one of us, and home isolation should be stopped once the symptoms resolve or the medical officer certifies that she is free. Now, I wouldn't go much into the detailed treatment because we as obstetricians do not play much role in the medical treatment. People like Dr. Pate and others involved in day in and day care or night out care of these patients should be involved. But prophylaxis after exposure is still a big doubt. So we do not know whether we should give them HCQ after they have been exposed, because the advantage of starting HCQ is not proven, but you can start hydroxychloroquine up to 800 milligram per day, azithromycin for 5 days or 10 days, but you have to support them with at least 1 gram to 4 gram of vitamin C, about 100 milligrams of zinc. Vitamin D, as I said, studies have shown that people who have vitamin D deficiency had more chances of getting ICU admission. Now, doxycycline or second line, which is otherwise given, is still, we wouldn't say should be given in pregnant women, but because that is not my prerogative. I would not advise total medical treatment under my supervision, but you will give them all the instruction to be in touch with me. If there is any breathlessness developing, measure your SpO2. If there is any problem, take care that visitors don't come. All those washing of clothes, separate plates, everything has to be followed very strictly when you're advising These are the other drugs which I think already has been discussed about paracetamol, antenatal steroids, this favipiravir, which is some new prednisolone. I wouldn't go into the IL-6 inhibitors or the remdesivir. These are all for moderate and severely ill patients. So we should definitely admit them where proper COVID care is being given, and this patient who is not in labor but who could be COVID. As I said, most every patient you have to think that they are COVID. Even if their RT-PCR is negative, they could be in the asymptomatic phase. So definitely you have to monitor them if they are going into moderate, and ICU care will be required if they fall into those SARI criteria and the quick SOFA score, which might indicate. So we wouldn't waste much time today in all those things. I'm sure most of us are aware. Again, ICU management is required for those very serious. Let us not go and waste much time. We can answer quite a lot of other questions which you'll all have. Now, this will be another clinical situation. Patient who was COVID positive at 32 weeks, 34 weeks, now has recovered. Now she's come to you that I want to deliver at your place after 2 weeks or 3 weeks. So this is going to come very frequently now to most of us. She wants to use your center for delivery. So this is where minimum 21 days after her initial symptom or RT-PCR, most of them would be not contagious. So that is what the current evidence definitely says, but still follow all universal precaution and investigate them before they come for delivery. Apart from a CBC, you will complete LFT, which could be elevated. CT chest, if you think the respiratory symptoms are quite high, with an abdominal shield, but at 34 weeks, 35 weeks, direct CT also is permitted, but just for medical legal, one can put an abdominal shield. Other investigation which definitely one has to do closer to term are CRP, LDH, ferritin, IL-6, and D dimer. If these are all, these are all cytokines and other immune reactions which, if high, indicate that there is some reaction still going on. So we have to be careful. So one has to go through the normal levels, because D dimer, if it is very high, patient has a higher chance of DIP and will require proper care. Now, patient coming in labor, as I already mentioned, directly take them into a particular room where they are going to want to stay or for the next 2 or 3 days. So they should always alert you advance that they are going to be admitted, and only one, and either use a private transport. Do not use, I would say, the personal car or an ambulance which is dedicated for COVID should be the one, and whoever is there at the reception should be in proper PP, and the doctor who is going to examine always should be in full PP, and restrict all those attendants, even your hospital staff. We dedicate only one nurse. That same nurse will continue to monitor till her duty is over. So no multiple attendants getting exposed. And always counsel your patients that our Indian mentality is always, when somebody comes in labor, there are at least 10 or 15 people, relatives, waiting outside the labor room to cheer and to really greet the newborn baby. But today that is cannot be allowed, and as I said, there could be an hypercoagulable state, because and you will need to start many of them in low molecular weight heparin. Timing of delivery need not be changed just because somebody has COVID-19 infection, unless the patient is too serious. Means it's her life which is at question and she is just breathless and requiring ventilator. Their emergency cesarean has been. Otherwise, induction is not advised in the presence of active COVID-19 infection. And during labor, as I already mentioned, cover the face with mask, with a face shield, and everybody inside should be completely protected from that aerosol, which is going to be continuously. And there is no scientific rationale to deliver all infected women by cesarean. It is, as I said, only for the protection of the healthcare workers. There is an increasing tendency to do little more cesarean section. Prostaglandin, which we use commonly for postpartum hemorrhage, avoid using it because that can cause vomiting, and vomiting causes aerosolization, more chances of corona coming. So wherever possible, methyl ergometrin can be used with caution. Labor analgesia is permitted if you have an experience and anesthetist is used to it. Spinal epidural is quite safe. General anesthesia as such is condemned in COVID time. but they also should be in full PPE at all the time. And this is another clinical situation which I'm sure most of you get faced, where we have done a delivery where the RT-PCR was not done. The patient has come before term and she had a delivery or a C-section, and then post-delivery you come to know that she's turned positive. And you're already the healthcare workers, your room, your operation theatre, everything has been exposed. So if you have taken that universal precaution, very less chance of anybody contracting. So that is why unknowingly to get exposed is where the mistake is happening for the healthcare workers. So for every case, be in full PP. The area has to be completely sanitized and fumigated minimum 6 hours to 24 hours. That is what the local authority also advocate. The patient, if cesarean is done and she turns positive, she should be kept inside your hospital in an isolated room with a toilet facilities. You're supposed to inform the local authority, and you can start the recommended medication even if she is asymptomatic. All those staff, all those doctors have to be quarantined and observed for symptoms and test them soon so that if they are negative, they can resume to work. And
ते तर मोठा ह्याच्यात करायचंय ताक.
any
हा?
attendant who is with the
काय?
pregnant should be treated as COVID
ते
19.
मोठ्या ह्याच्यात काढून करायचं.
Now, as far as
त्याला
breastfeeding,
बाहेर
this
काढलं
will be a common question.
ते मला स्वच्छ करावं लागतं.
That the mother and the child always
काय
should be
काय?
separated, but today WHO also says there is no justification. Breast milk can be given in an asymptomatic COVID patient unless she has got a lot of symptom and is breathless or requires an ICU where the child will be isolated. But the direct contact can be done, but the mother should be always wearing that protective mask, and baby born to COVID mother should be tested at least 48 hours and after 1 week. Sometimes they say every week also, but it has not been found in breast milk, and that is a great sign. But the mother should be continuously following all those, and before handling the infant should have hand wash, should be wearing that mask, and the rest of the time the child should be away from the mother. Antibodies may be transmitted, so that will give a protection to the child. But what I would again emphasize is your own healthcare workers, your nurses, your ward boys have to be trained in going through all this, because this has not been the routine for decades. We have never done all this till about March or April, and today we are told to do so many things: not touch a patient, don't touch the file of the patient. So all these things we have to take frequent meetings. We have to allocate their duties, boost up their morale, and even in them who are above 60 and with comorbidities should be given, and there should be a proper administrator looking after all that duty distribution. Apart from all those PPE kit which you are going to, we have to keep their team spirit high. If they don't find the doctor also working in full precaution, willful all the time, their morale is going to go down. So you have to be present, give them psychological support. Of course, keep them catching, keep them warning, give them warning when you find them they are not in the proper protective gear, which I showed you, and you can at times give them little bit extra additives to really when they have been supporting. Uh, you have to give them, whether to give them this prophylaxis again is a matter of debate, but it is worthwhile giving, because like what Dr. Shashank Joshi, who is a COVID task force member, did say that those healthcare workers who were on prophylaxis hydrochloroxicon had more better chances of recovery, less chances of going into ICU than starting it later. Then of course I wouldn't waste much time in cleaning all your areas, all your instruments. I think everybody is well aware you should have proper fumigation. You should have that regular cleaning up of your the table where the patient is being examined, the lift, all with hypochlorite, and all your instrument proper cleaning, the linen, everything has to be properly sterilized before it is put into reuse. And definitely much time has to be spent. Now, MTP, which is going to be very common now, because many patients who are just pregnant around these 2 3 months, all are coming for MTP for the fear of corona. You can convince them that there is no harm right now proven, but most of them are still scared. There is no harm in giving them MTP services, preferably today with the availability of medications. mifepristone and misoprostol, life has become easy because you don't have to give them general anesthesia. Emergency contraceptive pills can be prescribed by telemedicine. Only certain drugs are there, but this can be prescribed on telemedicine before any patient does come for MTP. Now, how I will be remaining a COVID-free clinic or hospital? I am sure that is in the mind of every one of us. Corona I cannot escape, but how will I remain COVID-free? How my staff I can protect? How can I do that? You have to pray to God. We do it TDS, sometimes even QDS, but you have to test, and test. Be always vigilant. Mean definitely your vigilance is going to make you at least to great extent COVID free. Now, just taking through this COVID infection timeline, around 10 or 15% are going into that severe category. That is what the statistics says. So these patients, 15% of them are going to be contagious till about 28 days after their initial detection or after the symptom. First few days they are not with symptom in the first 3 4 days, but after the fifth day, even in patients who are asymptomatic, they are supposed to be having viremia or contagiousness till the 14th day. Patient with mild or moderate symptom, they are contagious till 22nd day, but others will be contagious for almost a month. So this classification will have, but as I said, severe and critical, we are not going to really handle as obstetrician. We are going to see this most of the time asymptomatic or with mild symptom. But remember that viremia lasts for about 14 days in patients who do not have symptoms, and about 21 days or 22 days in patients who have mild symptom, and that is where their infectivity is lost. And this will help you to schedule your delivery, your cesarean or surgery. So this is very, very important. I'm sure you have understood this, but today for serosurveillance, we are lucky that this COVID antibody test is available, called as the COVID TAP, which we also do at our center now. But remember, this is purely for serosurveillance. This is for not diagnosis of COVID-19. This will detect antibodies. But unfortunately, it cannot differentiate IgM, IgA, or IgG. It will give you only the presence of all three combined, but it is very vital that it is recommended for all healthcare workers, doctors, your nurses, all should be doing it to know whether do you have the antibody. So now if I look at this chart, which is a little busy, I'll try to explain it in a little simpler way. If antibody is positive, either the patient or the healthcare workers is just had a recent infection or an infection more than 3 weeks back. The patients who are antibody positive, if they show symptoms, they should go for RT-PCR. If they are showing RT-PCR negative, that means what? They are already protected. They are not in infection. They can be definitely taken up for surgery or taken up for work. But somebody who is antibody positive and RT-PCR positive, that means he or she is likely to transmit infection, has to be isolated like a regular COVID patient and follow all those precautions. If antibody is negative, viral is also negative. That means you have never been exposed like most of us. So you have to take all that full PP precaution all the time. If antibody is positive, negative, viral is positive, again, the patient is in active stage of infection. So this will help you to triage your own patient, whether you can take them for delivery soon or cesarean or for any surgery. Even for every one of us, I think antibody testing is now the order of the day for at least to know that we have been exposed till that time or not, and we continue. And today when we do both of them, we will have three group of patients. Somebody who is negative for PCR RT or antibody also negative, then he is a named patient. Means he has to follow all those precautions all the time. Now we are not sure whether the antibody protection lasts for more than 5 days or 5 months, sorry, as of now, but we have to wait whether you get immunity for a longer time. But patient who is PCR negative but antibody positive means he is immune. So he can be little more easily taken for surgery, but with all the still precaution which is recommended. But somebody who is PCR positive, and either antibody positive or antibody negative is an infected patient, keep him away from your clinic, admit them in specialized or dedicated COVID centers, and be away. And that is how you can keep your clinic COVID free. So thanks for a patient hearing. We all agree that Corona has taught us a lesson of a lifetime. We have to respect the learning curve. We have to avoid the mistakes and repent later because our old habits die hard. As Madam Curie has said, nothing in life is to be feared. It is only to be understood. And remember, courage isn't a matter of not being frightened. You know, it is being afraid and doing what you have to do anyway. So we have to take care of our patients. My recommendation is use protection, 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 and remain safe till the time we all get immune or some vaccine whereby we can blow away the virus like any
गाड़ी
sort of
दे वापस आई तुरंत ही
thanks for a patient hearing.
9 सेंटीमीटर है पेशेंट रेडी नहीं सेक्शन
तू यहाँ से कर रही है मॉडरेट?
हाँ अभी क्या करूँ लैपटॉप पे हूँ
तो भी तुला कळलंच नाही का माहितीचे सगळ्या
I think the others have to mute their mic. A lot of voice noises keep coming in between.
Hello.
Yeah.
Thank you, sir, for a wonderful presentation. Now I request Dr. Ashwini Madam to please summarize the session.
Thank you, sir, for a great presentation. So definitely Corona is everywhere. And as sir said, protection, protection everywhere and every time. And Corona has taught us to do practice in a new way. Telemedicine has given us a new way. Antibodies can be transmitted to the child, but infection through placenta is very rare. Management of pregnant patients is as same as other adult patient. And main thing what sir said is protection, protection, and protection. I request Dr. Hemant Patil sir to ask questions if any audiences have any questions to sir.
Dr. Mansi, are you there? Okay, so we'll take question. Sir, we take one by one question.
Yeah.
What is the role of cautery, or how should we go about use of cautery in the surgery?
Right. Now, every aerosol generating, now cautery, we know, is runs on the tissues, the protein, the water droplets all fly. So definitely it is going to be there. So new guidelines as far as use of cautery is come up. Now there are cautery where when it gets activated, the suction automatically starts. There are HEPA filters, there are HULPA filters which are available where you are going to suck out. So use your cautery to the minimum setting if you think you require, and you have those suction evacuate the all smoke evacuators machines or gadgets are available which have ULPA filters and HEPA filters. If you have them, good. But otherwise, you can have your regular suction very close to the area where you're going to cauterize. Keep the suction on so the smoke, once it comes out, it is there, immediately gets sucked out. But still, whether viral particles which will be there in the tissue and will get infection to the health is still not proven because inside the intestine, coronavirus has been found. Whether it is present in the abdominal area is not yet proven, but this is the question which is recommended by most of the societies.
Okay. How to handle peritoneal fluid and amniotic fluid in this situation?
Correct. Now, as of course, as I said, coronavirus has not been found in the amniotic fluid. So maybe there can be later on report that it is present. So you have to see that you suck out everything during a cesarean, and of course, everybody has to have a full PPE, including the nurse or whoever is assisting, completely even the leg cover with a complete gumboot shoe so that it doesn't fall onto your legs, body, and any part. And other peritoneal fluid suction is always mandatory. Use appropriate amount of suction and a machine and mop if required.
Okay. Is COVID-19 test mandatory for all the patients who come to us?
No, not for the consulting, no. But there are reports by the even which have come in the World Journal of Surgery that asymptomatic COVID patient who were operated and who came later on positive, there was a mortality of 26%, which is so high. So unknowingly, if you operate on a COVID patient, their chances of getting ICU admission is 50%, which is tremendously high. So it was proven that in even in non-emergency cases, the mortality rate was almost 60%, 16%, and in emergency cases it was almost 28%. Which of your patient will agree to have mortality? So it is better you do for the patient safety, apart from your safety. You are going to be exposed. So definitely, I would recommend that any patient coming for any surgery today, corona test has to be done. Antibody test you do first. It is available. If it is positive, you can wait and then say that you are immune. You can go ahead and do the surgery. But definitely should be done.
Okay. Sir, is there any role of tubal ligation during LSCS in non-COVID patient?
No, tubal ligation can be done. There is no contraindication for tubal ligation in COVID time just because family planning is something. Today, if you are doing a Caesar and somebody wants TL, you have to go ahead and do the TL with all the care required because family planning service, the government of India will never say stop or halt. So that has to be done and that can be done.
No, I mean, the question is it advisable?
No, this, as I said, complications are more known in any this scenario. But a patient undergoing TL and ending up in complication of COVID, the medical legal implications are different. So if you can counsel the patient and convince them to do it later, it is always better. Because
Are
TL
there
mortality, TL morbidity is always a big headache for a gynecologist.
okay? Are there any trimester-wise guidelines, sir, for treatment?
So treatment is routine. Trimester wise, I told you the visits which have been already mentioned. Between 20, 18 weeks and 30 weeks, you need not call the patient at all. They can monitor at home, they can do the urine albumin at home and show it to you. Is there a heuristics are available? They can just do it at home and show you. They can do the GPT and WhatsApp the report to you. So the visits are reduced. Whereas the treatment for a non-COVID patient is same. But for pregnant patient with COVID morbidity, the treatment guidelines as of now is same as what is it for the general public.
Okay. Uh, Madam, any questions from your side? Ashwini, madam?
Sir, antibody testing, is it available in private labs?
Yeah, it is available now with our center also. We have tie up with SRL Fadke. So our lab here is at JK is managed by SRL Avinash Fadke from Dadar, and they have started not only RT-PCR in our hospital since last 2 months, but antibody testing since last 4 days. So it is available with just a 2 ml of blood which is required, and the report is available next day morning.
Sir, cost of it, please.
I think roughly it is 800 or 950 rupees. 800 or 950. I'm not sure, but roughly 800 950, I think. They charge.
Okay, sir.
Sir, what to do if a patient delivers and later she turn out to be positive in our own hospital?
That is what I told you, the clinical situation 3. Patient
Okay.
delivers, after some time we come to know she is COVID positive. Yes, if you everybody has worn that full PPE all the time, the ADMC told us that you don't have to worry. You are
Okay.
protected. Now, only the patient, after a cesarean, you can't shift her on the same day just because she is positive and you have operated. Separate room with toilet facility, you dedicate a nurse who was assisted in the surgery to look after the patient. Give her full PPE and she can be designated a room next to that same patient. Preferably keep her isolated, don't have much movement of other patients around that room, but you have to just follow all those guidelines. The operation theater or the labor room should be sanitized with hypochlorite, soap water, and fumigation. Before you can restart. You have to monitor, and the hospital doesn't get sealed if you have taken all these precautions. And of course, your staff who was there is assisting should be tested after 3 or 5 days. If they develop symptoms earlier, you have to test.
Okay. Okay. I think we have taken.
Yeah, there are few questions which are asking whether where to admit in Dombivli Kalyan. Dombivli area pregnancy patient we are done. That is
Yeah.
where the problem is today. Unfortunately, we do not have a dedicated COVID maternity set up by the authorities here, and that is where quite a few of our patients are getting trouble finding a bed. When I asked the question other day to the municipal commissioner during the IMA meeting, the epidemic officer did tell that we can arrange to take them to Nair Hospital. That is what the tie-up. Now today morning we had a patient. By morning we WhatsApp report that there is a patient named Mrs. So and so is positive. But when we tried to trace her, we couldn't get her name. They did not saying their maternal name, but by the time we could locate who that patient walks into the hospital with leaking. So immediately we have contacted the local ward officer. They arranged for an ambulance to shift her. So that is the only thing which we are doing at the moment.
Okay. Okay. There is one question that do relatives offer their help uh, in by wearing PPE?
No, if they want to remain with the COVID patient after they come to know, they have to wear PPE and if they but the guidelines say that we should not allow them to be exposed.
Okay.
Even care workers knows how to take care in full PPE, whereas a common man will not know how to take care of COVID patient in full PPE. So ideally, it should not be. Yeah, if they are going to give a replacement, if that is the correct, uh, uh, which is recommended for COVID, the 90 GSM and all these things, you can definitely do that.
Madam, any questions from your side?
No, sir.
Okay. So,
Thank you, sir.
Thank you,
Thank
sir.
you. Thank you. So, Mansi, your patient is delivered. Okay, thanks to you all. Thanks to all participants. If any query is there, they can always call me up and still take some advice or guidance.
Yes, sir.
I think I've done my best, although we do not handle directly. That is how I said about non-COVID treatment. We are all experts, but COVID treatment, we cannot really give you great advice. Thank you.
Thank you.
thank you, sir. Thank you very much. There is just a small announcement that there are few projects announced. They are being rescheduled, and the updates will be posted on our group. Okay. Thank you, sir. I thank you, everybody, every member who has been logged in and made this program successful. Thank you.
Thank you, sir.
Thank you.